And welcome to the Dr. Bob Show. Are you worried about your weight? Most people are, and most of the time it's because we're getting too heavy. We exercise, we try and eat well, but still sometimes our weight just gets too much. Are we a candidate for weight loss surgery? Will that help? What are the indications? We'll be spending most of this show talking about weight loss surgery. My guest is Dr. Stephen Boyce. He's a bariatric surgeon and has been doing this over 20 years. He'll answer our questions. Hello, I'm Dr. Robert Overholt, and I'll be your host for the next 30 minutes on the Dr. Bob Show. Later on, we'll talk about Alzheimer's. Is there a cure in the future? How close are we to a cure? And how do we control allergies? 60 million people have it. Is there any new treatment that will be more successful than what we have now? A lot of information for you. You'll want to stay tuned. We're talking with Dr. Stephen Boyce, bariatric surgeon, been doing bariatric surgery for 20 years, has been a guest on the Dr. Bob Show before, and we're going to see what's new. Steve, welcome to the Dr. Bob Show.
Thank you so much.
Tell me, how did you get interested in bariatric surgery, weight loss surgery?
Well, when I was doing my surgical training, I had the great fortune to meet a Dr. Otto Wilbanks. He was one of the pioneers of weight loss surgery in the United States, and he came over and would offer to teach residents who were interested in it how to do weight loss surgery.
And where was that?
That was at Parkland Hospital in Dallas, Texas.
Oh, I can. Parkland's a wonderful hospital. Have there been new things that are evolving in weight loss surgery?
Constantly.
Yeah, and that's what really why I wanted to discuss some of the newer things.
Sure.
But let's go back to some of the old. One of the initial ones that really sounded like it would be easy was lap bands. Now tell me what those were, gastric banding or what?
Right, the adjustable gastric bandings. The laparoscopic convention was a great innovation for that procedure, and they put a little adjustable balloon inside the band so you could adjust the tightness of it. And the idea is that it was to provide restriction to the flow of healthy food into the stomach, forcing people to slow down and hopefully reduce their portion sizes.
Did it work?
It did work. It did work. Help
And
lose weight.
the problem with gastric banding, is it still in favor or is it going out of favor?
It's really going out of favor, Dr. Bob. It's being replaced by some newer procedures like the sleeve gastrectomy. And the reason it's being replaced is because there are a lot of long-term complications with the bands.
Ah, so the band's going out, and you mentioned gastric sleeve.
Yes.
Now tell me, what is a gastric sleeve?
The gastric sleeve is a resectional procedure done on the stomach to reduce the size of the stomach and take away some hormones that cause hunger after you eat. And so patients have very good satiety, and they don't have much of an appetite after surgery, and they eat less.
Now that hormone is ghrelin. It's in the greater curvature of the stomach. So are you, with sleeve surgery, are you taking out the greater curvature of the stomach?
Yes, sir. You're taking out the greater curve as much as 70 to 80% of the stomach.
Wow. Well, let's look at a picture and let's look and see if we can get an idea of what that looks like when they do gastric banding.
Sure.
Or sleeve surgery, excuse me.
Yes.
So here we have a loop. There's a stomach, and is that the cut? You tell me what this is.
Yes. The large stomach is there, and then you'll see a dotted incision line, and the portion of the stomach to the right of the picture is removed. That's the greater curve that you were mentioning, and that's where ghrelin in the stomach is produced.
So when the ghrelin is produced there, if you don't get ghrelin, then you don't get hungry.
Correct.
Or you get less hungry.
Yes.
What is dumping?
Well, the dumping syndrome is what happens if you put either fat-rich or sugar-rich foods into the duodenum or the small intestines. And so there's a little valve at the end of the stomach called the pylorus, and pylorus means gatekeeper. So it controls how fast food leaves the stomach. So most patients with the sleeve gastrectomy do not have the dumping syndrome because they get to keep the pyloric valve.
Oh, good. Do you like that procedure?
I do like the procedure.
Who's a candidate for it?
Patients are a good candidate for the sleeve gastrectomy if they are at least 100 pounds overweight and perhaps have some other diseases resulting from that, like diabetes or high blood pressure or maybe even sleep apnea.
And you know, and that's the nice thing. Obesity hurts people from a high blood pressure standpoint, from a cholesterol standpoint, from diabetes, from sleep apnea. When people have surgery and they lose that weight, do sometimes those go away?
They do, and that's really one of the main goals. Because if we can get those diseases to resolve, then we won't lose people to those diseases every year.
When you take out, you say you take out about 70% of the stomach.
Yes, sir.
How long does it take what's the eating like after you get through, and how long does it take them to get better?
Well, right after surgery, of course, patients are on a purely liquid diet for 2 to 4 weeks. And then they go through a progression of pureed phase to soft foods to regular food over time.
Over time, let's say a year, how much weight have they lost?
You know, usually my patients will lose about 65% of what we call their excess weight. So if they're 100 pounds overweight, the average patient then would lose about 65 pounds.
What do you do about those other 35?
Well, at that point, they're usually down to a reasonably healthy weight. You know, a patient can be technically overweight and from a medical standpoint not have a lot of health risk. So our goal is to get them out of obesity, get their BMI, if you will, below 30. My goal is 28 or less for my patients.
Now, do you force people or recommend people or guide people toward losing weight before the surgery?
Oh, absolutely.
Why is that?
Because that is the one thing that we can do before surgery that reduces surgical complications.
So you have them go on a weight loss diet. Can most people lose weight during that period of time? You recommend it?
Most people do. My patients can lose weight in the short term. Their real difficulty is keeping the weight off long term.
I've had 2 or 3 patients that have had surgery under your guidance and have done so good. What does the patient say to you when they come back? Are they weak? Do they feel, because they've lost so much weight, do they feel tired? Or do they still have a lot of energy?
You know, initially after surgery, fatigue is a big factor because frankly, they're not getting very many calories. But after they've lost the weight, 6 months, 3 months later, in that range, boy, they are energized and excited about what's happening.
Now, the people that I've seen really haven't, that you've done the surgery on, they just say, I feel good and I've got a lot of energy. Do you have to replace certain vitamins and nutrients?
Yes, we have formal recommendations from our societies recommending the appropriate vitamin and mineral supplementation after surgery. So we follow their guidelines.
We're talking with David Easterling, and we're talking about bariatric surgery. David, how much weight have you lost?
I've lost an incredible 280 pounds.
280 pounds. When did you have your surgery?
Well, it was December 7th, 2009, so it's about a year and a half.
A year and a half and 280 pounds. How has that changed your life since you've had surgery? What's improved? Several medical problems.
Well, you know, pretty much everything is better now than it used to be.
How about your joints?
I had arthritis. It was really bad. And, you know, my joints, my knees aren't a problem anymore. That's not a problem. I don't have sleep apnea anymore. No sleep apnea.
So your sleep apnea went away.
It went away within about 6 weeks of having the surgery.
Oh, that's fantastic.
No more snoring. I slept through the night, you know, for the first time in years, I guess.
How about activity level, being able to be active, walking, talking?
Well, it's amazing. I go to the gym 3 to 4 times a week, and I work out. I work out on the treadmill, and I lift weights. We go hiking. Saturday we went hiking. We missed the rain.
How far can you hike?
Well, you know, usually it's a couple of miles, you know, something like that. You know, we just go for enjoyment. But I went to Mammoth Cave, and, you know, that's a big hike. There's a lot of stairs involved. I could have never done that before.
How about your breathing studies, your breathing tests, medical breathing?
Yeah, a couple of years ago, my breathing was very severe. In fact, when I went into the hospital, they were wondering why I wasn't on oxygen all the time when I went in for my surgery.
And now?
And now it's completely normal. It's very normal, and I don't have any problem with breathing or walking or going upstairs or anything.
Give me your experience about what you can eat and what you can't eat, and how fun it is or how difficult it is on eating.
Well, I tell you what, you know, when I first had my surgery, for those first couple of weeks, you know, it's kind of a liquid diet, and then for about 6 weeks, it's kind of mush. You have to blend everything up. But after that, you know, you go on phase 3 of the diet, and you can eat small amounts and, you know, drink small amounts and that kind of thing. But then after about 6 months, you're really kind of back to, you know, you can try most everything that you want to eat. The thing is, I just don't want to eat as much as I did before. But I can pretty much eat anything now that I really want. Nothing really bothers me too much.
David Easterling, that's a great story. Thank you for coming to the Dr. Bob Show, and people are going to love what you've done and think about doing it themselves.
I hope so. It really has changed my life. Every part of my life is better, and I really appreciate the opportunity to share that.
We're talking with Dr. Stephen Boyce, board-certified surgeon, does bariatric surgery. We talk about the gastric band sort of going out of favor. We talked about sleeve surgery, where we remove about 70% of the stomach. It forms sort of a banana shape, and people lose about 65% of their weight that they want to lose. Is that about right, Steve, so far?
That's exactly right.
Let's pretend we've got a patient that comes in that weighs 422 pounds.
Okay.
Really super overweight, and they come to you for a weight loss surgery. Tell me about how you guide that patient.
Right. Well, I really try to match the operation that fits that patient the best. Now, that patient would have at least 200 pounds to lose, and each of the operations have a sort of limit to how much they'll help people. That patient would probably be best served with what's called a duodenal switch.
Duodenal switch. Now, you talked about the duodenum being a gatekeeper, sort of. Tell me about duodenal switch.
The duodenal switch's operation is a variation of an operation called the biliary pancreatic diversion.
Wow, that's a big long word. Biliary pancreatic diversion. Okay, let's go through it.
So I just call it the switch, or the duodenal switch for short. But it's been around for about 40 years.
40 years.
It's an excellent operation that involves a limited sleeve gastrectomy, where we're trying to take out about 50% of the stomach, and then a bowel bypass of about 60% of the small intestines.
So how do you're going to bypass the small intestine, or 60% of it?
Yes.
So the first part or the last part you bypass?
We bypass the first part of the small intestines.
And the purpose of the initial part of the small intestines that we're going to bypass, that's purpose is what?
Well, you do absorb a lot of iron and calcium and calories in the small bowel. So the idea with the duodenal switch is that initially it's restrictive, because when people eat they get full very quickly, but over time they get to where they can eat very normally, but they can maintain their weight loss because they're only using about 8 to 9 feet of their small bowel, and they just don't have time to absorb a lot of calories.
So do they get diarrhea? Do they get loose stools? Do they have problems with that? How do you handle that?
You know, they certainly can, but it's usually caused by the diet. If they eat a high protein, low carb, low fat diet that we recommend, the average patient will have 1 to 2 bowel movements a day.
So that's really pretty good.
It's not bad. If they go out and eat a good old country fried meal, though, they're going to have some diarrhea.
So let me have you go through this for me. When we swallow, food goes into the stomach.
Yes, sir.
It's a fairly large bag. It goes out of the stomach into the duodenum, down the small bowel. So let's go through the duodenal switch again. Tell me exactly what you do.
Okay, so the first thing we do is a limited sleeve gastrectomy, kind of like the picture that we saw on the animation earlier. But instead of removing 70 or 80%, we take out about 50% of the stomach. So the stomach's reasonably large still.
But it's small enough to where you're getting rid of some of that hormone, the ghrelin or the
Yes,
ghrelin?
you certainly do.
Okay, and so you're not as hungry. The stomach is a little bit bigger, so there's a little bit more food that it can hold on to,
Yes.
and yet we're going to lose more weight because?
Because of the bowel bypass in the long run.
Now, how do you bowel bypass?
What you do is you divide the duodenum in half. So you separate the stomach from the duodenum. Then you go down to the colon and you measure backwards about 8 or 9 feet of bowel and divide the bowel right there. You take that first end next to the colon up and hook it up to the stomach, and then reconnect the other two about 4 feet from the colon.
So when I eat food, it goes into the stomach, then what does it do?
It'll go out the pylorus and into that distal part, or the lower part of the small bowel, and then from that point It's only 8 or 9 feet until the food goes into the colon or the large
So
intestine.
you bypass about 12 feet of digestive small bowel. If I remember, the small bowel is it 20 feet?
Yeah, 20, 23 feet in that range.
Somewhere in there. So you bypass all but 8 or 9.
Yes.
And that 8 or 9 has the ability to digest a little bit, and
Yes.
And then the food goes into the colon
Yes.
from that small bowel.
And then it's eliminated out of the body. A nice way to think about it is a person will absorb 60% of the protein that they eat, 100% of the sugar,
Uh-oh.
and only 25% of the fat. So it restricts your ability to absorb calories, but you need to eat a high protein, low carb, low fat diet.
So now what would be an example of high protein? Is that egg, beef,
Yes.
beans, that type of situation?
Sure, lean meats, baked or grilled.
And less fat. We all know what fat is. We just got to learn what happens if they eat a lot of carbohydrate and fat.
If they eat a lot of carbohydrates, their weight loss can be impaired and they can produce a lot of gas because those sugars go into the colon undigested where the bacteria live, and then they ferment it and produce a lot of gas.
So we learn that we
Yes.
eat right food like we should be eating anyway. So we've got a high protein, low carbohydrate. And what do we do about the fat that we're eating in our diet?
Right, you need to limit it because just like the carbohydrates, there's consequences to eating too much fat. And if you eat too much, the patients will get diarrhea.
Now, on this surgery, the duodenal switch, how much weight are we going to lose? We started at 400.
You know, if a patient had 200 pounds of excess weight, I would expect them to lose at least 170 pounds.
So, boy, that would be getting really skinny. When somebody has lost 170 pounds or 180 pounds, somewhere in there, is their skin get loose? Do they have to have plastic surgery after that for the skin?
You know, the patients are very concerned about that, and that's one of the most frequently asked questions at the initial consultation. And many of them do benefit from that. And there are some really new, exciting weight loss, skin reduction procedures used for weight loss surgery patients.
Oh, so it's the plastics, are they done by plastic surgeons or the general surgeon?
Both.
Both. So there are ways that you can use the flabby skin, get rid of it, so
Yes.
it looks like good body tone. That's fabulous. Any other thing new that's coming out in weight loss surgery? So far, it looks to me like the gastric sleeve,
Yes.
then the duodenal switch are the main ones that people have. The really obese people get the switch, and the people that need to lose 100 pounds,
Yes.
or so, which is a lot of weight, the gastric sleeve is a possibility.
And the gastric bypass is still around too. It's in the mix.
Do you ever go from, if somebody's had a gastric sleeve, they've lost 100 pounds, but they need to lose some more, do you ever take that sleeve and make it into a switch?
That is an excellent point, because that's how the sleeve gastrectomy got started. It got started because surgeons who had really heavy patients who were not good surgical candidates, and they wanted to try to do something simple first. So they were going to do a duodenal switch, but they said, okay, I'm just going to do the sleeve first, help them lose 100 pounds, get them healthier, then bring them back and we'll finish it. So yes, you can do it as a staged procedure.
Good. So if you do the sleeve first, they lose 100 pounds, they're going to have the duodenal switch later. How long is it between those two surgeries? A year?
About 6 to 12 months.
6 to 12 months.
Yeah.
What are some of the interesting stories that you've seen?
Oh, fascinating stories. A woman came in the office today and she had had her duodenal switch, and she was coming in to see me about skin reduction. And she had just seen her son, who had not seen her in a few months, and he did not even recognize her. So her own son didn't recognize her.
Facial features, when I lose weight, I get gaunt, but the people that I see that have had weight loss surgery, their faces look good, and they look good. They're happy, they smile.
Yeah, the patients who are following the protocols and eating high protein and taking their vitamins, they actually do look very healthy. Sometimes you'll see patients after weight loss surgery who don't do it right, though, if you will. They don't take their vitamins, they don't eat right, and they don't look so healthy.
Do they get on an exercise program? Do you make sure they do that and follow up?
Yes, sir, we do.
Steve Boyce, what a great surgeon and what a great help you are to people that have a problem in our United States that, to me, that's the only way to fix it, or it's the best way to fix it, or if it can't be fixed, there's an answer for it. Which category do you fit in? Have you tried to lose weight and you can't? Know that bariatric surgery is an option and you need to learn the information on it. I want to thank Dr. Steve Boyce for his excellent discussion, and now we're going to be talking about, stay tuned, Alzheimer's, allergies. I want to thank Dr. Stephen Boyce for his excellent discussion on weight loss surgery. And now for questions from you, the viewer, that I think will be important to your health. Question number 1, Dr. Bob, will we ever get a cure for Alzheimer's disease? Well, yes, we will. I thought we would have one by now. There's a lot of research going on and a lot of possibilities. Let me talk to you about a couple. First of all, Alzheimer's disease is because of 2 different proteins that are in the brain. They get there in a greater concentration than they should be. The nerve fibers inside the brain become tangled because of these proteins, and they're so tangled that you can't give thought processes and you lose those thought processes. So what can we do about amyloid protein, which is one of those proteins, or the tau protein? Amyloid protein, there's 2 things that we can do. Since it's a protein, we can take amyloid and throw it in a bucket and develop antibodies against it. Those are called monoclonal antibodies. We use monoclonal antibodies in lots of other illnesses, and they neutralize the bad part. And they can neutralize this amyloid protein. We've got one that's just out. It didn't work as good as they wanted, but it's a great possibility. The other one is to get a vaccination where we can inject into the arm protein, amyloid protein, to build up resistance against it. It was done several years ago. There were 14 people. 9 showed dramatic improvement, but 2 of those died of encephalitis, so they took that study away. Now in Japan, they've got a recent study that they've got a vaccination where they lowered and altered the protein in the vaccination where they're getting excellent results. If we can find Alzheimer's early, then those patients age 60 or above that have early Alzheimer's, then who knows? Maybe we've got a cure in the future. I certainly hope so. It's a devastating disease on the patient and on the family. And it's getting to be where we have to have more caregivers to take care of these people. Thank you, caregivers, for doing such a good job. Hopefully the medical profession will get that cure. Next question, Dr. Bob, how are we going to ever get rid of allergies? Well, we need to get rid of Alzheimer's disease. 30% of the population is allergic. It used to be 20% of the population. Now it's 30%. It seems like pollution is driving the immune system where more and more people are developing allergies. How can we control the immune system? Well, we're never going to avoid pollen, dust, mold, and animal dander. If we can't avoid, then we've got good medicines to control symptoms, antihistamines, steroid sprays. There's a new spray called Dymista that has a topical cortisone and a topical antihistamine. It's the best new medicine that we have available to the current date. But what can we do to make the immune system not be so active against pollen, dust, mold, animal dander? Well, again, this is the allergy shots, and now there are allergy drops. The allergy shots, we inject a small amount of the allergen into the arm. The antigen or protein goes to the lymph nodes, which produces a protective antibody. As that happens, the allergic antibody begins to fade away. It's a 3-year program. People have to get shots on a regular basis to keep their immune system developing protection. Well, what happens if we don't inject that protein, but we put that same protein under the tongue, or we swallow that protein? Will that develop an immune response? Several years ago, a lot of this was done in Italy and in Spain, where they put drops under the tongue, and they felt like the results people were getting was protection and loss of the allergic antibody. At first in the United States, we thought they would have to have too much of that protein. But it looks like with the drops that you have to put under the tongue every day, that it does build up an immunity, and it does get rid of the allergy. There are still some questions that we don't know about how long the effects are. We feel like it's safe where you don't get allergic reaction. We're very high on the possibility of the drops. The FDA has not approved this yet. It is not covered by insurance companies, but know in the future that we'll be able to put drops. We're starting to do that with some foods in research. Small amounts increase the dose where we become tolerant or we have less reactivity to peanuts, eggs, other foods. A lot in the future is desensitizing. It's all the time that we have for this show. Remember, got to be exercising. That exercise will do for us what we want. It will lower our blood pressure. It will reduce stress. It will help us lose the weight that we want. Eat properly. We all know the foods that we should eat. Pay attention to what you eat. Eat slowly. Between each bite, put your fork down. Don't eat so fast. Eat the good foods. Get 8 hours of sleep. You'll feel good. You'll be rested, and the people around you will notice how efficient you are in your work. And most of all, what do we like? It's that laughter in your life. Find a friend, laugh a lot, tell stories, giggle. The more laughter you have, the healthier you will be.